Now, let's look at this 84-year-old female. She has a history of bilateral rhegmatogenous retinal detachment and known history of non-exudative AMD in each eye. She has hypertension and hypercholesterolemia and a brand new hip on the right side. Now, with color fundus photography, we clearly see an increased drusen load in comparison to the previous patient, with much more obvious or clear RPE abnormalities in each eye. Once again, infrared reflectance imaging, despite being imperfectly focused, once again, especially in this right eye, we see that there's a much larger area of the retina that is impacted. Is a greater extent of drusen versus what we see by color fundus photography alone. Let's look at the OCT of the right and left eye. If we start with the right eye, we're looking just superior to the center of the fovea. And again, we're going to move through the OCT scan by scan. What we see overlying this central drusen is number one, RPE irregularity and loss with ellipsoid zone loss and outer nuclear layer loss. This outer retinal loss is causing the inner retinal layers to fill in those gaps. We also see choroidal hypertransmissibility, or increased light that's able to pass through that abnormal outer retina and RPE. Moving inferiorly just towards the center of the fovea here, we see our first hyperreflective foci, the combination of anteriorly migrated RPE cells with potentially activated microglia, another important risk factor for progression to late-stage disease. Now we see this turbid, irregular drusenoid pigment epithelial detachment, once again with overlying RPE change and increased signal extending into the choroid, reminding us of that damaged RPE, ellipsoid zone, and outer retina. Now, this last scan right through the center of the fovea, we see these this elongated impacted area, almost this flat, irregular large pigment epithelial detachment. I will say this is an area I'm very cautious about investigating for the presence of macular neovascularization. In the left eye, right off the bat, starting center, just superior to the center of the fovea, we see an excellent example of reticular pseudodrusen or subretinal drusenoid deposits. Moving through the retina, once again, this large drusenoid pigment epithelial detachment with hyperreflective foci. And moving inferiorly, we have this one particular drus that looks a little bit different from the other drusen that we've seen. Its core is hyporeflective, and it is associated with hyperreflective foci once again. Now, let's take a closer look at just that particular drus. Now, this is not something that we would do clinically, but a really valuable exercise to understand the natural history of watching what happens to a particular area of the retina over time. In 2020, we see this irregular, more typical type of drus that's present. By 2023, it increases in height and it becomes more hyporeflective with already early overlying RPE change. And by 2024, we see that the core is truly hyporeflective. There is increased choroidal hypertransmission and overall increased RPE migration. Now, what's happening to this particular drus over time? What's happening is that it's becoming atrophic. This is an example of what's happening, that this drus is going to become atrophic over time. Now, let's look at the progression more objectively. Once again, we see the drusen volume indicated by the RPE elevation in the 5 and 3 millimeter circle. In the right eye, this patient's drusen load started very close to zero, and we see that increase over time. Now, my biggest question in looking from 2023 to 2024 is this patient, are they at their maximum drusen volume? Is that volume truly starting to stabilize or reduce, increasing the atrophy or diagnostic or impacting our evaluation of atrophy over time? By a similar token, in the left eye, we started with a much higher drusen volume with overall some variability. But once again, maybe this patient has reached their peak and they are at the tipping point where this drusen volume is now beginning to decrease because this patient is moving towards atrophy. Now, as I mentioned in the right eye, that flat or low-lying irregular pigment epithelial detachment has me very cautious about the potential presence or development of choroidal neovascularization in the macular region. OCT angiography is a really valuable tool to evaluate for non-exudative choroidal neovascularization, or a choroidal neovascular membrane that hasn't yet broken through Brooks membrane RPE complex. Where we're looking for the structural presence of choroidal neovascular membrane is in the sub-RPE space and at the level of the choriocapillaris, which at this present time, there is no evidence in the right or left eye of choroidal neovascularization. We've seen two very different cases with different risk factors for progression to late-stage disease. It's not just about identifying those risk factors, but utilizing objective measurements in evaluating patients for change over time. Now, Carolyn, I will hand things off to you.